My name is Gina del Peso. My topic is Olaparib plus Bevacizumab as first-line maintenance in ovarian cancer. Definition: Bevacizumab is a drug that has been shown to shrink or slow the growth of advanced-stage epithelial ovarian cancer. This drug seems to work best when given along with chemotherapy, working well in terms of shrinking tumors. Bevacizumab is in a class of medication called angiogenesis inhibitor. For cancer to grow and spread, they need to make new blood vessels so they can nourish themselves. Cons. These cons of this medicine mainly are the adverse effects, which can be dizziness, loss of appetite, heartburn, a change in the ability to taste food, diarrhea, weight loss, changes in voice. Pros. This use in combination with certain chemotherapy drugs in patients with a recent ovarian cancer diagnosis, when the cancer is even old, in previously treated patients whose cancer has come back. Application in nursing. This medicine is given as an infusion into a vein every 2 to 3 weeks. Be aware of common side effects such as high blood pressure, tiredness, bloating, low white blood cell counts, headaches, mouth ulcer, loss of appetite, and diarrhea. Video.
Patient selection is very important when entertaining putting a patient on bevacizumab. I think it's important to remember that the 2 phase 3 trials that led to approval in the platinum-sensitive space included patients with a good performance status. These patients, by and large, especially with GOG 213, where we knew more about patient selection, excluded patients who had a history of inflammatory bowel disease or bowel obstruction or impending bowel obstruction. And with doing that, we can definitely decrease the amount of GI toxicity, such as perforations, that we see with these patients. The other thing is understanding their background, past medical history, and concurrent diseases such as hypertension. And I think it's important to monitor the blood pressure carefully during treatment, and we find that we're able to keep patients on the right dose without dose delays with aggressive blood pressure monitoring and intervention. The efficacy is very good. I have had patients who've had complete responses in the platinum-sensitive setting. I have seen patients who've had large volume ascites who've had near complete resolution. I've had patients with pleural effusions who've had near complete responses as well in this setting, and I think that is exhibited by the data where, again, you go from the mid 50% to the chemotherapy regimen, and by adding Bev, you bring that up by 20-some%. So it's impressive, and that's what patients want to see as well. They want to come in, they want to see that their CA-125 is going down, that their symptoms are diminishing, and that's very important to the patient. For me, there's an important decision to make with administering bevacizumab in the platinum-sensitive setting, and that's really what chemotherapy backbone am I going to use? Am I going to use carboplatin with gemcitabine, or am I going to use carboplatin with paclitaxel? And I have to look at a number of variables to make that decision. One of the things I look at is what the treatment-free interval has been, longer makes me tend to go more with carboplatin paclitaxel versus carboplatin and gemcitabine. I also look at the logistics of the schedule. The gemcitabine is administered on a day 1, day 8 schedule. The paclitaxel could be administered weekly, but in GOG 213 it was given every 3 weeks, which can be an advantage for some patients who don't want to have to come into the medical center as often. Then I also look at what kind of symptoms did the patients incur from their frontline treatment. So for patients who have a lot of neuropathy, for example, that's a perfect candidate in my mind to go with the platinum and gemcitabine.
Use applied in Ecuador. In Ecuador, a study has been carried out such as one from the San Francisco de Quito University, where the treatment of cancer patients using bevacizumab is evaluated, and it was found that they eventually had an improvement in their health. Video.
Bevacizumab right now is approved for use in ovarian cancer because it's very expensive, because it has some pretty significant side effects potentially, and also because the improvement in outcome is somewhat marginal. It's not used universally in the United States. It's used in some instances in Europe, but not in the United States as much. It certainly is being used in the recurrent setting. But in this study, we're looking at patients with a primary diagnosis of ovarian cancer and whether adding bevacizumab to standard therapy improves the outcome. That molecular subtyping could potentially predict which patients will respond to this drug bevacizumab. And that's important because patients, we would like to give the bevacizumab to patients who respond to the drug, not to those who won't respond to the drug. If we give bevacizumab to patients who don't respond to the drug, all they're doing is having higher costs and more toxicity, really without any benefit. So it's very important to be able to determine who responds to this ahead of time. When I'm seeing a patient in clinic, I don't care how well bevacizumab does in 100 patients. I care how well that's going to improve the patient outcome for the patient who's sitting in front of me. So that's what the study's about. It's about determining which patients are more likely to benefit from bevacizumab, not in a population, but individualized treatment. We had 4 different groups that contributed to this project. One, the MRC, which performed the initial trial in the United Kingdom, AGO in Germany, which collected the samples, Illumina in California, which did the sequencing, and then the data analysis was done at the Mayo Clinic. So we wouldn't have been able to do any of this without all four of those groups contributing, so that's very important. It's very important that our results are corroborated in other groups of patients. So our findings today are very significant. We're really excited about them, but they really need to be corroborated in another group of patients before they can use them.
Conclusion. Bevacizumab is a drug used as part of chemotherapy treatment for patients with ovarian cancer. Bevacizumab is in a class of medication called angiogenesis inhibitor. Their job is to slow or stop the growth of tumors. The care that must be taken is the same as for other types of chemotherapy. Strategy video.
Before we move to recurrent disease, I want to talk about this idea of adding Olaparib to GOG 218 or bevacizumab. And that's being tested, and that will be a report, hopefully, within the next year or so. Tell us about the study, which you know as Paola-1.
Paola.
You keep
Paola-1. Paola.
What do I say?
Paola. You do say it funny.
Go ahead, Paola. You just say it loud.
Say it loud, Paola.
Paola.
So this is an important study. It is a randomized study. It's entirely done in Europe, where bevacizumab has been incorporated into frontline maintenance in almost all countries for many years. And so it is the standard of care. So all patients received platinum taxane chemotherapy with bevacizumab. And then at the time that they finished, if they were in complete or partial response, they're randomized to continue bevacizumab maintenance plus placebo, or they get bevacizumab maintenance for 12 cycles, because that's the standard in Europe, and 24 months of Olaparib, just like Solo 1. With primary endpoint is investigator-assessed progression-free survival. Stratification factor is BRCA patients. And there's a fair number of BRCA patients, not over-enriched, but there's a fair number of BRCA patients on that study. And of course, this is pre-Solo 1, so you wouldn't randomize a BRCA patient to a non-Olaparib arm anymore, but we're going to have that data coming out. So this is not really just a Me Too sort of study. There is real preclinical and translational evidence that there's synergy between PARP inhibition and anti-angiogenesis agents through a number of mechanisms that lead to downregulation of DNA repair proteins and an induction of kind of a BRCA-ness behavior that then will respond to a PARP inhibitor. So that's going to be an important study, mainly, and it'll be hard to tell. I think, honestly, if you ask me, I think it's going to be positive. I don't think they're going to break out the subgroups.
They have to.
Well, they may not, but if they do, I'm most interested in the BRCA wild type, because I think that's really who's going to benefit.
Absolutely.
It's going to be hard to say.
Which is the majority of patients.
Which is the majority. It's going to be hard to say in a BRCA patient whether or not addition of bevacizumab adds anything over
50 months.
Over Olaparib alone. So that's going to be the unanswered question there.
So Brian, I hope I say it right. Paola. If Paola 1 is positive, meaning that you add Olaparib to the 15 months of bevacizumab to a level that's acceptable for regulatory, and then the BOOST trial, which is 30 months of bevacizumab versus 15, how are you going to stop the Olaparib at 15 months and then continue bevacizumab for an additional 15 months? Or are you going to try to make a case for giving both for 30 months?
Well, the Olaparib goes 24 months.
24, okay, there you go, good to know.
24 cycles.
24 cycles. Yeah. But still, the bevacizumab
could go longer.
Could go longer.
So just to highlight, what are we talking about here? We're talking about 24 months, 30 months for ovarian cancer first line, things that we've never talked about before.
How great is that? How great is that? Thank you for that.
So that qualifies the fact that I don't know the right answer.
Yeah.
I mean, I think if we could keep the Olaparib, I think it's the active drug. Keeping it on longer probably would make sense, but the BOOST trial will be interesting to see those results as well.
Thank you.